Hello everyone, and welcome. I'm excited to see you all here today. We will be exploring some important questions and options with answers, specifically focused on scenario-based questions. This is part 6 of the Qatar Prometric exam for nurses. Over the course of this presentation, we'll cover various types of questions that you might encounter, helping you prepare effectively. So let's get started and make this session both informative and engaging. All right, let's look at this patient. You can see they are pale, which suggests they might be bleeding or have poor perfusion. Their blood pressure is quite low at 80/50, and their heart rate is elevated at 130 beats per minute. These signs point toward hypovolemic shock, meaning they're losing a significant amount of blood or fluids. The key here is to recognize that the priority is to restore their circulating volume quickly. So, among the options, giving oral fluids isn't fast enough or effective enough in this critical state. Placing them in high Fowler's position isn't our immediate priority. While it can help with breathing in some cases, it doesn't address the shock directly. Giving sleeping medication would be completely inappropriate and could worsen their condition. So, what's the best next step? The answer is to start an IV line and administer normal saline rapidly. This helps to replenish their circulating volume quickly, stabilizing their blood pressure and improving perfusion to vital organs. This approach aligns with the overall theme of managing hypovolemic shock. Rapid volume resuscitation is crucial to prevent organ failure. Always remember, in cases like this, quick intervention can make all the difference. Now let's consider a common post-operative scenario. We have a patient who is 8 hours post-op and hasn't voided yet. Additionally, their abdomen is distended. This situation raises an important question. What should the nurse do first? The options include providing hot tea, assessing the bladder with palpation, giving a diuretic, or simply ignoring it until the next shift. The correct answer here is to assess the bladder using palpation. Why is that? Well, in post-op patients, urinary retention can occur for various reasons, such as anesthesia effects, medications, or pain. Palpating the bladder allows us to determine if it's distended, which indicates retention. It's crucial to recognize that bladder distension can lead to discomfort, urinary tract infections, or even more serious issues if not addressed promptly. Therefore, the first step is to assess before taking further action. This highlights a key point in post-op care. Always evaluate the patient thoroughly before intervening. Remember, understanding the patient's current condition helps us choose the safest and most effective interventions. This example ties into the larger theme of vigilant monitoring and timely response in post-operative nursing care. So imagine you're caring for an elderly patient who suddenly becomes confused at night. What's the first thing you should do? Well, the instinct might be to do something quick, but in this situation, the most important initial action is to assess their oxygen saturation and vital signs. This helps us quickly identify if there's an underlying medical issue, like hypoxia or infection, that could be causing the confusion. Restraints or sedatives might seem like quick fixes, but they're actually dangerous and can worsen the situation. Turning off all lights might help with comfort, but it doesn't address the problem directly. So always remember, the first step in managing sudden confusion is to assess their vital signs and oxygen levels. This step is crucial because it guides our next actions, ensuring we're responding to the true cause rather than just symptoms. It ties into our overall theme of thorough, careful assessment to provide safe and effective care. When you remove a wound dressing and notice purulent discharge with a foul smell, it's a clear sign that there might be an infection or some complication. Now, the most important thing to do here is to document what you've observed and notify the doctor immediately. This step ensures that the healthcare team is aware of the situation and can take appropriate action. Ignoring these signs or hiding the findings could lead to worsening infection or other serious issues. Cleaning the wound with just water or leaving the dressing off without proper assessment isn't sufficient at this point. Always remember, timely documentation and communication are key to effective wound management and patient safety. Imagine you're in a situation where a patient suddenly develops swelling of the lips and has difficulty breathing after an injection. What would be your immediate priority? The options might include reassuring the patient, preparing epinephrine, giving oral tablets, or offering water. In this critical moment, the most important thing to do is to prepare and administer epinephrine right away. Epinephrine is the first-line treatment for anaphylaxis because it can quickly reverse the severe allergic reaction. Reassuring the patient or offering water can wait, but acting swiftly with epinephrine is essential to prevent further deterioration. So, in this scenario, the correct answer is B, prepare epinephrine. This highlights the importance of recognizing anaphylaxis promptly and knowing how to respond effectively, which is a key part of our overall focus on emergency management. Now, let's consider a common scenario involving a stroke patient who is drinking and suddenly coughs. This is a critical moment to recognize because coughing during swallowing can indicate aspiration or difficulty swallowing, which is a common issue after a stroke. The question here is, what is the correct nursing action? Let's review the options. First, encouraging fast drinking. This is not advisable, as rushing can increase the risk of choking or aspiration. Second, stopping oral intake and informing the doctor. This is a more appropriate response because it prioritizes patient safety and ensures that the healthcare team can assess and address the swallowing problem. Third, tilting the head backward. Actually, tilting the head backward can sometimes worsen swallowing safety. A more typical maneuver is to tilt the head forward or to the side, depending on the situation. Fourth, giving large bites of food. Definitely not recommended, as larger bites increase the risk of choking. The correct action, therefore, is to stop the oral intake immediately and inform the doctor. This allows for proper assessment and intervention to prevent complications like aspiration pneumonia, which stroke patients are particularly vulnerable to. Remember, post-stroke swallowing issues are common and require careful monitoring. Recognizing signs like coughing during swallowing is crucial, and always responding promptly and appropriately can make a big difference in patient outcomes. Now let's consider a critical situation. The chest tube drainage suddenly stops, and the patient becomes breathless. What should we do in this moment? The first instinct might be to try to fix the problem ourselves, but it's important to follow the correct steps to ensure patient safety. The best action here is to check for kinks in the tubing and assess the patient's respiratory status. This step helps us identify whether the tube is obstructed or if there's a change in the patient's condition that needs immediate attention. It's not recommended to milk the tubing forcefully, as this can cause injury or increase the risk of infection. Clamping the tube or removing it altogether are also not appropriate responses without further assessment. Remember, ensuring the tube isn't kinked and evaluating the patient's breathing are crucial first steps. This approach helps us determine the cause of the problem and decide on the next appropriate actions, keeping patient safety at the forefront. Now let's consider a common scenario. A patient with diabetes refuses to take insulin before meals. So, what is the best nursing approach in this situation? Option A suggests forcefully giving the insulin, but that's not appropriate. We want to respect the patient's autonomy and understand their concerns. Option B is to ask the patient the reason for their refusal. And this is really the key point. Engaging in a respectful conversation helps us understand any fears, misconceptions, or issues they might have. Option C, ignoring and leaving, isn't ideal because it can damage trust and miss an opportunity to address their concerns. And option D, throwing the dose away, is clearly not a good practice either, as it compromises care and doesn't solve the underlying problem. So the best approach is to ask the patient why they're refusing the insulin. This shows respect, promotes open communication, and helps us provide better care. Remember, insulin administration isn't just about giving a medication. It's about understanding our patients' needs and working with them to manage their condition effectively. When a patient is scheduled for abdominal surgery and asks what they should expect, the most important thing I want to emphasize is the need for thorough preoperative teaching. One of the key aspects of this is explaining fasting requirements. It's crucial that patients understand how long they need to avoid food and drink before surgery to reduce the risk of complications like aspiration. This helps ensure their safety during the procedure. While other topics like billing or hospital policies are important, they are not the priority in this context. Providing clear, concise instructions about fasting directly impacts the patient's safety and overall experience. So, when you're preparing a patient, focus on explaining the fasting requirements thoroughly and in a way that they can easily understand. This sets the foundation for a smoother surgery and recovery process. Now, let's consider a scenario. A patient who is on IV fluids suddenly develops crackles in their lungs and starts experiencing dyspnea. What should we do in this situation? The key here is recognizing signs of fluid overload, which can happen if too much fluid is administered too quickly. The options include increasing the IV rate, stopping or slowing the infusion, giving more oral fluids, or just continuing normally. The correct action is to stop or slow the IV infusion. This helps prevent worsening pulmonary edema and allows the body to start adjusting to the excess fluid. Remember, fluid overload can lead to serious complications like pulmonary congestion, so early recognition and intervention are crucial. This ties into our overall theme of careful fluid management, monitoring patients closely and adjusting treatments as needed to avoid complications like IV fluid overload. Now, when we see a child with sunken eyes and poor skin turgor, these are classic signs of dehydration, which is quite common in pediatric patients. The key here is identifying the most appropriate parameter to monitor to assess their hydration status effectively. So, among the options, play activity, urine output, hair condition, or temperature only. The most reliable and direct indicator of dehydration severity is urine output. Monitoring urine output gives us real-time insight into kidney function and fluid balance. If the urine output decreases significantly, it suggests the child isn't retaining enough fluids, pointing to worsening dehydration. Play activity and hair condition are less immediate and less specific signs, while temperature alone can be influenced by many factors and doesn't directly reflect hydration status. Therefore, the priority monitoring in this scenario should be urine output, because it helps us quickly gauge the child's hydration level and guide our management accordingly. Remember, maintaining adequate hydration is critical in pediatric care, especially when signs of dehydration are evident. All right, let's look at this scenario. A patient is complaining of crushing chest pain that's not relieved by rest. This is a critical sign that we're dealing with a potential myocardial infarction or a heart attack. The key point here is that the pain is intense and persistent, and it doesn't go away with rest, which makes it different from angina. In such a situation, our top priority is to provide immediate relief and prevent further damage to the heart. The best action here is to give nitroglycerin as ordered. Nitroglycerin helps by dilating the coronary arteries, improving blood flow, and reducing the pain. The other options like giving a cold compress, letting the patient walk, or offering juice are not appropriate in this emergency. They won't address the underlying issue and could delay critical treatment. So remember, when faced with crushing chest pain not relieved by rest, the priority is to administer nitroglycerin promptly. This is part of the essential intervention for myocardial infarction, which we'll explore further as we go along. Now, let's consider a situation where a patient's abdominal wound opens slightly after a cough. This is a classic example of post-operative wound dehiscence. The key here is to act promptly and appropriately to prevent further complications. When you notice the wound opening, the first step is to assess the situation carefully. You might wonder, what is the best immediate action? Option A suggests applying a warm compress, which might provide comfort, but it doesn't address the wound itself. Option C is to push the wound edges together. This might seem intuitive, but it can actually cause more harm if not done correctly. Option D is to ignore it, which is definitely not advisable. The correct response, and what we should always do in such situations, is option B. Cover the wound with a sterile saline dressing and notify the surgeon immediately. This approach helps keep the wound moist, reduces the risk of infection, and ensures that a professional evaluates the situation promptly. Remember, wound dehiscence can be a serious complication, so early intervention is crucial to prevent further issues like infection or evisceration. This example underscores the importance of vigilance in post-op care and knowing the appropriate steps to take when complications arise. All right, let's walk through this scenario. When a patient is NPO or nil per os, meaning they haven't eaten anything but they have an insulin order for surgery, the first step is crucial. So what should we do? Do we give the full dose of insulin right away? No, that could be risky without knowing their current blood glucose level. Should we hold the insulin without checking? That might lead to uncontrolled hyperglycemia. Or should we cancel the surgery? Not necessarily, unless there's a severe issue. The correct answer here is to check the blood glucose level first. This helps us determine what their current glucose status is, so we can make an informed decision about insulin management. This highlights an essential point about blood glucose monitoring. It's a critical step in managing diabetic patients perioperatively. Regular and accurate blood glucose checks help us prevent complications, whether it's hypoglycemia or hyperglycemia, especially when the patient is NPO. Remember, always prioritize checking blood glucose before administering insulin or making any adjustments. This ensures patient safety and optimal surgical outcomes. Now, let's consider a common situation involving a patient with dementia who is trying to leave the unit. This behavior can be quite challenging, but it's important to respond appropriately to ensure their safety. So, what is the most suitable nursing action in this scenario? Option A suggests redirecting the patient calmly. This approach is key because it helps manage the patient's confusion without causing agitation. It involves engaging the patient in a different activity or guiding them back to a safe area gently. On the other hand, shouting at the patient, as in option B, would likely increase their agitation and confusion, making the situation worse. Locking all doors without supervision, as in option C, might seem like a quick fix, but it can be dangerous and isolating. Immediate restraint, option D, should only be used as a last resort and under strict guidelines. The correct answer here is a redirect the patient calmly. This approach aligns with person-centered care principles and promotes safety while respecting the patient's dignity. Remember, wandering is common among confused patients, so having strategies like redirection can help us manage these behaviors effectively and compassionately throughout our presentation. Now let's consider this scenario. A patient is 2 days post-op and has developed a fever of 38.8 degrees Celsius. The key question here is, what should we assess first? When a patient develops a fever after surgery, it's crucial to identify the underlying cause promptly. The most important initial step is to assess the wound site for signs of infection. This is because wound infections are a common post-operative complication and can escalate quickly if not caught early. Look for redness, swelling, warmth, pain, or any discharge. These are red flags indicating a possible local infection. While other options like checking food preferences, visitors, or bowel habits are relevant in specific contexts, they are not the priority here. The immediate concern should be ruling out a wound infection, as it could lead to systemic issues if left untreated. So the correct answer is assessing the wound site for infection. This step aligns with the overall goal of early detection and intervention, which is essential in post-operative care to ensure patient safety and recovery. All right, let's look at this scenario. We see a patient on oxygen whose saturation drops from 96% down to 85%. This is a significant decrease and definitely warrants our immediate attention. So, what should we do? The options might seem tricky, but the key here is to focus on checking what's happening. First, we should not ignore this change, because a drop like that can indicate a serious problem. Removing oxygen or turning it off abruptly isn't appropriate without understanding the cause, as it could worsen the patient's condition. The best action here is to check the oxygen connection first. Make sure the tubing isn't kinked or disconnected. Then, assess the patient to see if they're showing any signs of distress or other issues. This step helps us identify whether there's an equipment problem or a patient-related issue and guides our next steps. Remember, our goal is to ensure the patient gets the right intervention quickly, based on what we find during this assessment. So, the correct answer is to check the connection and assess the patient. That's how we ensure we're acting safely and effectively in these situations. When a patient says, "I feel like people are watching me," it's a very vulnerable and distressing statement. The best response in this situation is to acknowledge their feelings and foster a supportive dialogue. So, instead of dismissing their experience or telling them to stop thinking that way, we want to show understanding and invite them to share more. That's why the best choice is, "I understand this feels real to you. Can you tell me more?" This approach validates their experience, encourages open communication, and helps us understand what they're going through. Remember, in psychiatric care, empathic listening and validating the patient's feelings are key to building trust and guiding effective treatment. So, always aim to respond with compassion and curiosity rather than judgment or dismissal. All right, let's talk about a critical situation involving a diabetic patient showing signs of hypoglycemia. Imagine you see someone who is sweating and trembling. That's often a clear sign that their blood sugar is dangerously low. So, what's the first thing you should do? Well, the priority is to quickly raise their blood sugar level if they're conscious. Giving fast-acting carbohydrates, like juice or glucose tablets, is the most effective immediate action. It's important to do this right away because hypoglycemia can worsen rapidly, and quick intervention can prevent serious complications. Now, it's not just about giving the carbohydrate, it's about recognizing the signs early. Symptoms like sweating, trembling, weakness, and sometimes confusion are key indicators. Remember, the main goal here is to restore normal blood sugar levels swiftly and safely. And of course, always ensure safety. If the person becomes unconscious, you need to call for emergency help immediately. But in this scenario, since they are conscious, giving a fast-acting carbohydrate is the most appropriate and effective action. This is a fundamental part of managing hypoglycemia, which ties back to our overall theme of recognizing and responding swiftly to diabetic emergencies. All right, let's consider a common post-operative scenario. A patient starts vomiting after surgery. Now, what is the best action to take in this situation? First, it's not advisable to lay the patient flat, because that could increase the risk of choking or aspiration. Instead, the correct approach is to turn the patient's head to the side. This position helps prevent vomit from entering the airway, reducing the risk of aspiration pneumonia. Giving water quickly or ignoring the vomiting isn't appropriate either, as both could worsen the situation or delay necessary intervention. So the key takeaway here is that turning the head to the side is the best immediate action. It's a simple but crucial step to protect the airway and ensure patient safety after surgery. Keep this in mind as part of our overall focus on managing post-operative nausea and preventing complications. All right, let's look at this situation. The urine output has dropped to only 10 milliliters per hour over the last 2 hours. That's quite a low output, and it's important to figure out the cause quickly. So, what should we do first? The options are to remove the catheter, check for kinks in the tubing, pull the catheter hard, or ignore it. Clearly, ignoring it isn't a good idea, so we can eliminate that. Removing the catheter without assessing the situation could be risky, so that's not the best initial step. Pulling the catheter hard is definitely not appropriate. It could cause injury. That leaves us with checking for kinks in the tubing, which is a simple, non-invasive step. Sometimes, the issue is just a kink or a bend in the tubing that's obstructing urine flow. So, the first thing I want to do is carefully inspect the tubing for any kinks or obstructions and straighten them out if needed. This step is crucial because it's often the simplest fix and can restore proper urine flow. Remember, when managing Foley catheter care, always start with the least invasive, most straightforward assessment before considering other interventions. This approach helps ensure patient safety and effective care. 24 hours after a major burn, one of the most critical things to monitor is urine output. This parameter gives us a direct indication of the patient's fluid status and kidney function. It's essential because, in the early stages after a burn injury, fluid shifts can be profound, leading to hypovolemia or dehydration if not properly managed. While other factors like hair loss, appetite, and skin color are important in overall burn management, they are not as immediate or sensitive for assessing fluid resuscitation effectiveness as urine output. So, when we're keeping a close eye on our burn patients, ensuring they produce an adequate amount of urine, typically around 0.5 to 1 milliliter per kilogram per hour, is a top priority. This helps us gauge whether our fluid replacement strategies are on point and also alert us to potential complications early on. Remember, maintaining proper fluid balance is crucial for preventing shock and supporting tissue healing in these patients. Now, let's consider a patient who is drowsy but still arousable, and their breathing is shallow. The key question here is, what is the priority nursing action? Looking at the options, we have monitoring the airway and breathing closely, giving a large meal, ambulating the patient, or removing oxygen. The correct answer is, of course, to monitor airway and breathing closely. This is because, when a patient shows signs of drowsiness with shallow respirations, there's a real risk that their airway could become compromised. Ensuring the airway remains open and their breathing stays adequate is critical in preventing respiratory failure. This ties into the broader theme of post-anesthesia care, where vigilance for airway patency and respiratory status is essential. Remember, in the post-anesthesia period, any change in consciousness or breathing pattern can be a sign of complications that require immediate attention. So, always prioritize airway assessment and respiratory monitoring to ensure patient safety. When a patient refuses a procedure, it's crucial for us to respond appropriately. The correct answer here is B. Respect refusal and explain the consequences. This means that we need to honor the patient's right to refuse treatment while making sure they understand what that decision might mean for their health. It's about balancing respect for their autonomy with providing the necessary information so they can make an informed choice. For example, if a patient declines a certain test or treatment, instead of forcing them or threatening, we should calmly explain what might happen if they refuse, such as potential deterioration of their condition or missing out on important benefits. This approach fosters trust and supports patient-centered care. Remember, respecting a patient's refusal doesn't mean we're giving up. It's about ensuring they're fully aware of their options and the possible outcomes. This aligns with our overall goal of providing respectful, ethical, and effective care. All right, let's focus on this scenario. A child presenting with a fever of 39.5 degrees Celsius and a history of past febrile seizures. When faced with this situation, the first action is crucial. The correct choice is B. Remove excess clothing and give antipyretics as ordered. This approach helps in safely reducing the child's temperature without causing unnecessary discomfort. It's important to avoid heavy blankets, which can actually trap heat and worsen the fever, so option A is not appropriate. Giving aspirin, option C, is not recommended because of the risk of Ray's syndrome in children. And shaking the child awake, option D, is dangerous and can potentially trigger another seizure. Understanding the child's febrile and seizure history helps us make quick, safe decisions. The goal here is to manage the fever effectively while keeping the child comfortable and preventing further seizures. So always remember, the initial step is to gently reduce the fever with appropriate measures, like removing excess clothing and administering antipyretics as prescribed.